Welcome back, family, to the Doctor Next Door. I'm your host, Dr. George Korede. Today, we're going to talk about digestive health, colon cancer, gut health, probiotics, fatty liver disease, and much more with the gastroenterologist named Dr. David Fitch. How are you doing, Dr. Fitch?
I'm doing great, Dr. Korede. Thanks for having me.
So he specializes in digestive diseases, colon cancer, and screening. So I thought it'd be great to have him on the show so we can discuss some of these pertinent things that we should all know about. So I want to dive in, Dr. Fitch, with the increase in colon cancer in young people. What's going on there? What are you guys thinking about?
Well, we're starting off grim, Dr. Korede, but no, it is probably the most pressing issue within GI right now. And, early onset colorectal cancer, it has its own acronym and everything. It's sad that we kind of are at this space where we have to have kind of a special nuanced diagnosis category for young patients. But it is alarming. And in response, we've dropped the age of colon cancer screening down to 45. I know we'll talk about that a little bit more. But if you go back, in GI, we tell people they have colorectal cancer, unfortunately, often. But even within my short career over the last 10 years, that has been, the 60-year-olds who didn't get colon cancer screening ever, unfortunately come in with symptoms, we diagnose them. Now it's people in their late 30s, early 40s. It's now about 15% of the overall population is under 50, which is very alarming. And it's been increasing about 3% a year. And what's really concerning is we don't quite know why yet. Genetics stays pretty stable, right? And it's mostly sporadic cases. It's not all family history. It's not all genetic mutations that we know of. And so there's a lot of interest right now going in to try to figure out why we're seeing this next kind of wave of colorectal cancer. It's sad to tell anybody they have cancer. It's heartbreaking and tragic to tell a 40-year-old who has small kids that they have cancer. And colorectal cancer it's a rough one to have. It almost always requires surgery. The chemotherapy is rough. The surveillance afterwards is rough. And it really is heartbreaking. Hopefully we kind of have some progress pretty soon about how to kind of better triage patients.
Yeah, I mean, it's interesting. You hit a lot of facts there that now we're seeing it more in young people. About 50% of the cases you're seeing are actually in people under 50, if I understood you correctly.
15% of the cases are under
15.
Yeah,
15. Oh, sorry, 15%. Yeah. But still, that's an increased rate from what's typical. So, I think we've had an oncologist on here. They've played with the idea about the ultra processed foods, being more sedentary, having other comorbidities that may increase the risk. And all these are, don't quote us on these. These are just speculations at this point. But it's very sad to hear that more people, unfortunately, I'm in the Middle Ages, so, it speaks to me, of course, are getting that. So, not to start off on a grim note, we can screen and catch this stuff early, right, Dr. Fitch? How do we go about doing that?
The good thing is that colon cancer is pretty preventable. And so we can't prevent 100% of the cases, but very effective tools that we have. So colonoscopy has been the mainstay, the gold standard for many years. There are some non-invasive screening modalities that are helpful also. It's really important for patients to get the age-appropriate colon cancer screening, and that will stop majority of cases. And we'll hopefully be able to figure out, okay, who needs to have colonoscopy at age 35? Who needs to have it at 40, even without a family history? Is there a way we can assess the stool? Is there a way we can assess people's genetics and really kind of pin down families that need to come in earlier than even the normal screening age, which used to be 50. And a couple of years ago, we dropped it down to 45, depending on the society. But now pretty much all of them are in agreement that we want 45.
So at 45, male or female, you're due for a colonoscopy. Go talk to your doctor. Go get that done. So colonoscopy is a fancy sounding word. Could you break down what the heck happens during this procedure, Dr. Fitch?
Yeah, because it is something foreign to about everybody.
Yeah.
When you become that age, you need to have it done. The people get pretty worried about it because they hear these stories about overall, it's a very safe procedure. It's not a surgery. It's an endoscopic procedure. It really entails a couple things. So the day before, you're on a clear liquid diet. No American ever starved in a day, I can guarantee it. It's not the funnest day. You can still go to work, still do your normal activities. You're just a little bit more hungry that day. That night, you do a bowel cleanse, the first half of it, usually in the evening. It will give you a lot of diarrhea. That's what it's made to do. These drugs are very potent. They're now kind of smaller volume. They used to be these huge, big jugs that people worried about. We rarely have to give those. It ends up being about half that volume now. And you drink it gives you diarrhea. You go to sleep for a little while. You wake up early in the morning. You do the second half. You don't like me a lot by that second dose, but that's okay. And then you do need a driver to come with you because almost everyone gets sedation for these procedures. Most people don't remember anything about the colonoscopy. You come into the endoscopy center. We put an IV in. It's not general anesthesia. You don't get a breathing tube. The lights go off. It's about a 30-minute procedure. You wake up. The best thing about a colonoscopy, once you recovered and you hear that everything turned out okay, food will never have tasted better to you that day.
Very good. So it sounds like some caloric restriction, not eating, what you were affectionately referring to as diarrhea. You're passing out all the contents of your bowels so that
you do have to bowel cleanse. Yes,
it's
a purge.
It's
a marvel of medicine that you will get to experience because it's very effective.
So basically, what he's referring to as diarrhea, you'll be passing out all the contents of your abdomen or your GI system so that they can see clearly when they do the scope. And then I think one of the benefits of the colonoscopy is you can catch stuff and actually remove stuff, if I understand correctly, right, Dr.
Yeah,
Fitch?
so that's one of the mainstays of colonoscopy is that not only is it a screening test, so yeah, unfortunately, if you already developed colorectal cancer, we would take biopsies of it. We would identify the location. We would put a tattoo in there just so the surgeons would know where it's at. But more importantly, if you don't already have colorectal cancer and there's precancerous colon polyps, because in the vast majority of patients, colon cancer develops through these what we call tubular adenomas or sessile striated adenomas. They're just fancy names for polyps that do have precancerous potential. And if you let them grow, there's a chance that one of those can become a colon cancer in your lifetime. But if we remove them, obviously it reduces the risk, and it can reduce the risk of developing colon cancer up to 60 to 70% over the course of screening time. So it is a very effective tool. And, there are missed tumors on colonoscopies. It's pretty rare, but in general, it's a very high quality test. And our societies and our specialty have spent decades kind of refining this, get the bowel cleaned out really well, make it comfortable for patients, and make sure that we're doing a high quality job and removing these precancerous lesions before they can turn into interval cancers.
You spoke on the high quality nature of the colonoscopy. I know the Cologuard, you can do the stool samples and send those off as well. Can you kind of compare and contrast those a little bit, colonoscopy and the Cologuard?
Yeah, absolutely. So there's non-invasive screening modalities also, because we know not everybody wants to come in for a colonoscopy. Some people need a nudge. And those approved tests for screening people only. So the real important thing for those to know that if you have a family history of colorectal cancer, if you have GI symptoms, if you've been diagnosed with low blood counts, those are not the tests for you. You need to go straight to a colonoscopy because there's other things we could find that's not colon cancer. The non-invasive testing usually involve like a stool test. So you'll turn in your stool, you'll mail it in. Sometimes they still do in the doctor's office, but more times than not, you actually mail it in. And they are pretty good at detecting colon cancer. They're not very good at detecting colon polyps. The DNA-based stool test, Cologuard, is the very popular one. They have the best advertising team, and they do it during the Super Bowl. And it's an approved test. And I hate colon cancer. So anything that brings down colon cancer, I'm happy. We just want to make sure those tests are used in the right people. And also realistically, what I tell patients is that you could run, but you can't hide from the GI doctor. Eventually, those tests, they're made to be very sensitive because they don't want to miss things. And so a lot of times we have false positives. They do cause a lot of anxiety in patients, but they do catch about 92% of colon cancers. Now, to GI doctors, that's still pretty high. That's an 8% miss rate. Now, the newer versions may be a little bit better. The real life practice on these we also have some questions because a lot of times I'll see people that had one of those tests positive like a year ago, and it makes you cringe. It makes you pretty concerned. But they are approved tests, and especially in rural communities where there's not endoscopy around, they can be very valuable in that situation. A lot of countries outside the United States utilize FIT test, which has been around for 20 years. So non-invasive screening is not new with Cologuard. FIT tests have been around for 20 years, and it's pretty effective. It's done yearly. Cologuard's done every 3 years. There's a blood test called Shield that just came out. That it's kind of down on the totem pole a little bit because it has a pretty high miss rate, or it's not a very sensitive test, a better way to say that. And so that one I don't think is yet used for prime time a whole lot. We really need to see screening tests that catch 92, 95% of lesions before I really would strongly recommend them.
Yeah. So quick recap, because you unpacked a lot of great stuff there. Colonoscopy is the best test that we have available for screening early, removing polyps, and decreasing your risk of colon cancer or catching it early. There are many different ways you can check for this in regards in without doing a colonoscopy, excuse me. Cologuard, Fit test, Shield test, and these are ways to either check the blood or the stool to check if you have a risk of having colon cancer. But one of the key points you made was if you are high risk, right, you're having certain GI symptoms, blood in the stool, or you have a strong family history, you will probably need to get a colonoscopy in those.
Yeah, definitely any first degree relatives with colorectal cancer, those non-invasive tests are not approved for you. And the special thing about those population is, heaven forbid, your father gets diagnosed with colon cancer at age 45. You would start screening actually at 35, assuming there's not a genetic link that can bring you in even earlier. There's some people with Lynch syndrome and all these other syndromes that we have that start in their 20s for colon cancer screening because they're such high risk. And, second degree relatives, from a GI standpoint, a lot of those people also start at age 40. Sometimes insurance gives us some pushback, but we always are being more aggressive.
So basically your risk can change based on your genetics and if someone in your family has it, and that may increase you may need to get a colonoscopy a little earlier than other folks. Very good. So now that we've efficiently scared everybody, Dr. Fitch, let's move into something that's a little lighter. Probiotics. They put probiotics in everything. I don't know if you've noticed this. It's in yogurt. I think my wife's got a soda that she likes that's got probiotics in it. Probiotics for everybody, right? So what is the big deal with probiotics? How do they help? How much of it is hype? What's the skinny?
Even my kids' vitamins, the gummy vitamins, have like 10 billion units of something in it. In general, when you look at studies for probiotics, not overly effective. And so now there's so many products out there and only a few of them actually go through any type of study. There's no question that fermented foods, getting good organisms through our GI tract is pivotal. And it's probably one of the things that's missing in especially the American diet. And it may be causing the increased risk of colorectal cancer in some ways. We think that the microbiome changes, that sets up a area of inflammation or vice versa. And that may precipitate pretty much damage being done to the colon that can cause DNA issues and cancer down the road. Now, probiotics for things like irritable bowel syndrome, they've done quite a few studies, have not really shown any significant benefit. What I tell patients, if you're having those symptoms, get the assessment, make sure there's nothing more concerning. Then if really it's kind of for mild symptoms, I say, yeah, go ahead and do some probiotic for a month and just see how you feel. There's really no evidence that you got to be taking one of these pills every single day forever and ever. I'm sure their company would love you to do that.
Sure.
If people notice a really good response to it, that's fine. Do it for a while, then come off of it. What I tell patients, more importantly, eat real food, eat less processed food, eat more raw foods. If you want to get into fermented foods like kimchi and things, that's even probably better. If you want to drink some kombucha, go for it. They're not going to hurt you. The probiotics aren't going to hurt you either, but they do add up over time. And when people are taking lots of different supplements, they can be spending, $60 to $100 a month on supplements. And I don't know if there's a huge health benefit there.
Yeah. So, I mean, certainly the cost analysis, if you're spending $100 on probiotics and what have you, and there's not a huge benefit, certainly you want to reevaluate that. And I was going to ask, so kombucha, kimchi, any other versions of fermented foods that have some anti-inflammatory processes that may help?
Sauerkraut, good old-fashioned sauerkraut, especially I live in Ohio. Cincinnati is very German. There's a lot of sauerkraut. That stuff's great. And a lot of foods have been fermented over time. A lot of hot sauces and other sauces. And a lot of cultures do a better job of introducing those things, especially at young ages. It does have a bit of a different flavor profile than what most Americans are used to. So that's why it's not real common in our cuisine, but it can be very effective.
Absolutely. Thank you for that. Want to shift gears a little bit and talk about the gluten-free diet. Everything's gluten-free, right? Pizza's gluten-free. I think I tried a beer that was gluten-free one time. Who benefits from having a gluten-free diet, and should all of us be eating gluten-free?
Definitely not all of us should be eating gluten-free. About 1% of Caucasians have something called celiac disease, which is, think of a allergy meets an autoimmune disease. It's actually kind of unique. There's not a lot of other things that do this. And I've given some talks before in the past and why couldn't it have been kale? And why does it got to be gluten, which is so important to the, civilizations over time. Why does it have to be gluten? Outside of that, there is other ethnicities and other races that do get celiac disease, and they probably actually are missed more so than caught because we don't do the normal screening for them. Pretty much any Caucasian coming in to a GI symptom is going to get a celiac test. And part of that is it's really effective test. It's about 95% sensitive and specific. It's a blood test. If it's positive, you get an upper scope and we take biopsies of your small bowel. It's one of the easier things to diagnose, and it makes a huge impact on people's lives. But that's only one of the Caucasian population, even less so in other ethnicities. And so a lot of people have problems with gluten. It's probably the type of wheat you're eating, the processed nature of the wheat. If you have more like fermented, like sourdoughs and things like that, people probably would tolerate it more. There is a population that we call non-celiac gluten sensitivity. It's almost like an irritable bowel, bloating, and they seem to be more, specifically reactive to that. We don't necessarily know why that is, but we tell them to avoid it. But patients with celiac disease really have to be aggressive avoiding it. They don't even do well with cross-contamination. They have to be very careful when they eat out at restaurants. But in general, wheat is actually a really magical thing, and gluten is because of that, or gluten is why wheat is so great, and barley and rye also. What it does, it causes elasticity to food. It lets your bread get nice and big versus if you see a gluten-free loaf, it's like a pound cake. And actually, gluten-free foods are usually very calorie dense. They actually have to add a lot of sugar and unhealthy things to kind of mimic the flavor a little bit of gluten and get a better consistency. So I don't think it's overall a more healthy diet. Now, if you feel like every time you eat it, you don't feel well, eat less of it. Eat different forms of it, see what you can tolerate, but you don't necessarily have to avoid it 100%.
Yeah, so not everybody needs to be in the gluten-free aisle spending an extra $10 on bread because most people don't have it. And if you do have those symptoms, certainly try to go without it. So just speaking on sensitivities a little bit more, how do you diagnose these different sensitivities? Dr. Korede doesn't do well with lactose, right? Rumblies in my tummy, so I'm going to stay away from milk and certain dairy products. How do you diagnose these different sensitivities?
Yeah, so lactose intolerance is very common. We kind of evolved. We have a little enzyme that helps us break down the sugar in milk. We kind of lose that over time. You can get an illness that kind of wipes out your ability to do it even quicker. It's a little more common in African Americans than in Caucasians, but a lot of people struggle with that. And that's more of the sugar within dairy that gives people an issue. And that's not really a sensitivity necessarily. That's just an enzyme. You don't got enough of it. So what happens is then more of that sugar can go down into the small bowel and the bacteria love it and they ferment it and it causes a lot of gas and can cause diarrhea. It's generally not hurting people, but it does cause GI symptoms. Now, there is so many companies out there that will take your stool, your blood, your snot, whatever, and do some testing on it and say that you're not supposed to have X, Y, and Z. There's not a lot of good evidence for those. Patients will come in with this booklet of things that they spent $300 saying that I can't eat anything on here. And I said, well, then there's almost no food group you can eat. And in general, that's not a reliable thing. Now, there are people that have actual food allergies, and I do stress that they should go see an allergist, especially if they're having difficulty breathing, rashes and stuff, or even very significant GI symptoms to see if they do have a real allergy, and they can test that in the blood and they can do other testing. Those people are very important and should avoid those things. But in general, the food sensitive testing, I don't take a lot of stock in.
Okay, so probably more commercialism, trying to get you to buy their latest thing or whatever. See a food allergist or an allergist in general if you have significant reactions to certain foods. And then once again, with gluten-free stuff, not for everybody, but certain people may benefit.
Mm-hmm.
Okay, switching gears a little bit. Let's talk about something that's really near and dear to Dr. Korede's heart. The reason I can't eat a full pizza anymore since I left my 20s, heartburn. Heartburn is relatively common, as you know, Dr. Fitch. If you're having heartburn, a discomfort, feeling something behind your throat after you eat spicy foods, or sometimes not even without spicy foods, how do you recommend us go about evaluating that and then treating that?
Yeah, so that is the second most common cause of people seeing the GI doctor is for continued what we call heartburn or gastroesophageal reflux disease, or we call it GERD also. And it is pretty alarming. And there's people that are in the ER right now that think they're having a heart attack because they're having such bad reflux. Now, real important with reflux, because it's so common, we don't scope or do evaluation for every single person, especially young people coming in with those symptoms. But if you're having difficulty swallowing or those low blood counts, or you're vomiting, or you're losing weight, then it's very important to see a gastroenterologist because you will probably need some sort of endoscopic evaluation or imaging of the chest at least. The general people first always look at your diet, look at food triggers and see if you can cut back on that. Sometimes it is just a few food groups that kind of give you issues. And like I always say, eat less of it, eat it in different ways and see how your body responds to it. But there's a lot of people that have reflux to all sorts of things. And they do need medication, whether it be Tums, if the symptoms are real mild. Sometimes there's things like Pepsid or famotidine that are over the counter that people will take. And those work pretty well for kind of mild symptoms. But if people are having persistent symptoms, especially with the multiple food groups all throughout the day, they probably do need assessment because there are stronger medications that we use for longer durations. Also, especially Caucasians or even people that have had longstanding, rather persistent reflux throughout their life, we do actually screen those people for esophageal cancer when they turn 50. Now, Caucasians are a little bit higher risk. Caucasian males specifically are a little bit higher risk, especially if there's family history and such. And so even if you have mild heartburn symptoms, we do still do an evaluation for them as they get older. But for the average young person, they usually don't need a lot of intensive investigation, just kind of the right dietary modifications and sometimes pharmaceuticals.
So it's just everyday heartburn, your triggers, kind of limit that low, take less of it, try different ways, over the counter Tums. But if you're having significant symptoms and it's not getting any better, you're noticing blood or something, certainly check in with your PCP and gastroenterologist. Okay. So let's move on to something we're seeing a lot more in regular patients, fatty liver disease. So this is being diagnosed a lot more now. I don't know if it's just that we have better testing, Dr. Fitch, or is it more common in the Western world? Could you give us a brief understanding of what fatty liver disease is and how do we go about trying to prevent it?
Yeah, and it's another part of metabolic syndrome, and it's, obviously obesity epidemic, diabetes, hypertension, central obesity, all of that constellation of symptoms increase the likelihood of you having more fat within your liver. Now, that's one way of getting it. And then there's also people who drink too much. They can get another form of alcoholic fatty liver disease, and they actually are very hard to tell apart. So it's important to take a good history there and kind of look at, those risk factors. Now, fatty liver disease is a huge issue, actually, and we are getting better at screening for it. But even in my short career, it used to be hepatitis C as the biggest risk for getting liver transplant. Not anymore. It's far and away fatty liver disease because there's such a large population that's coming through that have had those risk factors and they've had them since their 20s and 30s. And over time, that fat in the liver in a lot of people can cause inflammation, elevated liver enzymes. And over time, a small subset of those people will get scar tissue within the liver. And that scar tissue is what can progress to cirrhosis of the liver. And that's what we want to avoid. So nowadays, especially people that have those risk factors, we screen them. There's different calculations we can just use on your blood test. And if you're low risk, that's all we do. We tell you to lose weight, and sometimes we'll put you on pharmaceuticals. But there are some people that we need to screen more aggressively for fatty liver disease, especially if there's a family history of cirrhosis and things like that. We have like tests that are kind of like ultrasounds of the liver that give us a scar tissue test to say, okay, is this somebody that just has bland fat in their liver and we're going to tell them to do all the lifestyle modifications? Or is this somebody we have to follow really intensively and be very aggressive about them losing weight or getting on the right medicines to help mitigate that risk of developing cirrhosis?
Good. Thank you. Yeah. So sounds like a metabolic disease in the same constellation with high blood pressure, diabetes. You end up with these changes that cause fat deposits in the liver. Usually if it's rather mild, we're just talking about changing your diet, losing weight, etc. But if it's more progressive or severe, then you'll probably have to see someone like Dr. Fitch to figure out what's the next best steps. You
Yeah, and
did hit.
we always rule out all the other causes, the viral infections, and it is, usually it's, as with everything, weight loss is key. It's a hard thing to do in American society, but it's really, really important. We'll talk about diet, Mediterranean style diets, cutting carbohydrates, trying to lose 10 to 15% of your body weight in a year. That can be really, really impressive. You'll see people's liver enzymes that are elevated and all of a sudden they just drop off once they've kind of met that threshold. And it's really important to see that early on, and longer that process is going on, the more damage is being done to the liver. And we always say the liver can take a joke. It's one of those organs that can regenerate itself. It's pretty cool that it can do that. But when you start stacking injuries, so people that drink too much and they have fatty liver disease, they get in trouble earlier on at younger ages. People that have hepatitis C and fatty liver, people that have, you know, iron overload and other issues that can hurt the liver. When you have fatty liver, in addition to that, we just know the injury is more serious, it progresses faster, and unfortunately causes cirrhosis.
Thank you for that. You hit on alcohol a few times. Can we talk about the association of alcohol with liver disease?
Yeah, and I think the main question that people want to know is how much can I drink? And
That's what our listeners want. You're right. That's what our listeners want to hear.
that is what the people want to know.
That's right.
And we used to say, 2 drinks for adult males and 1 drink for a female. I'm not certain where those really firm guidelines came from, but they sounded good and people liked it.
That's right.
More and more from a cancer risk, we know that really not any safe level of alcohol. And whatever improvement maybe from a cardiovascular standpoint they saw early on in studies, whether it be red wine, and is probably not worth it compared to the other risks that you get for it. So like everything in moderation, most adult males can probably have that 1 or 2 a night. It probably won't cause real significant liver cirrhosis or anything in their lifetime. Females, on the other hand, are much more sensitive to alcohol. So that 1 drink may still be too much for them. And where people really get into issues, when you get that 3 or 4 drinks, that really overwhelms the liver's ability to detoxify liver or detoxify alcohol, and it causes a real injury. And the binge drinking population actually do a lot worse than the daily drinkers. And so that, I wish I could tell people, oh, this is the number of drinks you can have safely. Some people can have more than others, but there's probably not any healthy amount of alcohol that I can recommend.
Yeah. So that association there with, it sounds like injuries to the liver in general, which, if you have fatty liver disease, all these other things, plus alcohol, it's just another level of injury to the liver, unfortunately, increasing your risk for all sorts of stuff like cirrhosis. But also on its own, it's recent realization across all medical societies that it's just increasing your risk of cancer in general. And interestingly, stuff I'm reading, it's not just liver cancer, right? I mean, alcohol can increase your risk of all sorts of cancer. So not here to poo-poo all alcohol, so don't cancel Dr. Korede and Dr. Fitch. I'm just saying that we know now much more about the risk of cancer in general with alcohol. Speaking of which, let's talk about supplements. Are there any supplements that you recommend? You mentioned diet briefly. Maybe you can speak a little bit more on that. I know you said the Mediterranean diet, but supplements, things that we can ingest, foods that are liver protective, perhaps?
So there's a whole field of liver detox that kind of came around in the last 5 years, and patients will bring these bottles into us. Milk thistle is a very common one. That's been around for a long time. So a lot of them will have, milk thistle in it. Not really good evidence that it does much, honestly, for the liver. There's some people that even have this probiotic that they drink before they drink alcohol to try to detoxify, and it sounds nice. It's got good marketing. Really, I haven't seen any robust evidence that it actually does anything. What I tell patients, there's not one supplement that you need for your GI tract other than eating fiber and drinking a lot of water. That's the stuff your GI tract loves. That's what all those trillions of bacteria you have in your GI tract that actually help with your immune system and do a bunch of roles throughout the body are super important. They want fiber. They want a lot of water, probably less American food, to be completely honest. But you don't
Shots
need to
fired.
go, you don't need to go and spend a lot of money on specific supplements for the GI tract. We already talked about probiotics. That's probably the biggest class for the GI tract itself. But unfortunately, there's not a magic bullet for this. It's the long term, lots of fiber, eating real food, eating diverse food is also really important. I think one of these things to talk about is a lot of people kind of get set in their ways and they eat the same 5 things every day in different forms. That's not fun to me. There's so much good food out there. Be experimental, try new things, see what fits. Try some fermented food, try vegetables that you can't even say the name at the grocery store. Why not? I think that's a good way to learn to like more things, and it gives you probably more diversity within your diet, which probably gives your microbiome a better chance to be successful for you.
Well stated. Yeah, I think that's good knowledge. I mean, I think the Mediterranean diet is often highlighted, but just a diverse diet, I think, is an interesting way to look at it. Certainly vegetables and stuff like that, which, I think the chicken tender and French fries warriors out there may not want to hear that, but, we got to eat a diverse diet, right?
Yeah, and all the rave right now is like carnivore diets. And I see people coming in with these huge protein diets, and there's a lot there. We want to unpack it all.
I was going to say, here we go.
I talked to a lot of these guys that they're not eating any vegetables. It's like, well, that can't be good for you.
Yeah, I think so. Yeah.
And
yeah.
I think high protein diets can be safe for the body. Just make sure you're
Sure.
coupling with a lot of fiber, a lot of water.
Sure.
But I don't think, people that are not eating meat, I think they can also have very healthy diets. And there's a lot of
Absolutely.
different cultures that have done that in different ways and been
Sure.
successful. And
Absolutely.
so my big thing is eat real food. If your food comes in a box or a bag or in a wrapper, be a little bit suspect of that to start off. If you can eat whole foods, and it's really important. And I know we're all busy, but I think it's super important to be able to cook and be able to kind of make your own food, because you know what's going into it. Then you're also going to save yourself a bunch of money.
Absolutely. And, we are not here to debate the finer points of the carnivore diet or the plant-based diet, but I will say that any extreme diet that excludes whole food groups a lot of times lacks certain nutrients, right?
Mhm.
So you'll see certain vitamin deficiencies if you just eat plants and you don't eat any meat, vitamin B12, for instance. And if you just do the carnivore diet, sometimes you can lack certain vitamins. I won't list them here because I'm not trying to get canceled. But the point is just that, you probably need a balanced diet, diverse, as you said, to get the full benefit from all the nutrients out there. So it's well stated.
Yeah, the liver healthy diets and the good GI diets, the Mediterranean diet has always been probably the most rigorously studied. And that's a great diet. And that's one of like my favorite foods to eat. But if I live in Ohio, I look around, you can't eat a Mediterranean diet all year round. It's
That's
too
right. That's right.
expensive. We're not in Italy. We're
Right.
not in Greece.
That's
And
right.
so you have to be a little bit more creative about just eating real food, I think. And I think that gets you most of the way there for most patients.
Yeah, 100%. Well stated, sir. All right, so we've stolen a lot of time from you today. My last and final question is: if you have 60 seconds in front of America today, you want to say one thing that they could do to improve their gut and gastrointestinal health, what would you say?
The diversity of diet, I think, is really important. And the one thing I always touch on, and most GI and liver docs will always touch on it, the best studies ever done in any healthcare is all the stuff in black coffee. It's from a liver health standpoint. And then there was one that just came out from a cardiovascular benefit.
I think I read this.
It was like 5 cups, but that's a
Yeah.
lot. And that's
That's
a
what
lot of
hey, that's coming from 2 docs. We're like, that's a
yeah,
lot.
I mean,
Yeah.
that's hard for me to get 5 cups a day. But even 3 cups a day from a liver health standpoint, especially those patients prone to fatty liver disease, really shows a great decrease in fibrosis. And it's been so many studies, too many studies have done on this because doctors just love coffee.
We will fight over coffee, correct?
Yeah,
Yes.
we're going to keep on doing studies showing how cool it is, and we're going to keep on drinking more and more coffee. So I tell a lot of my patients, this is a weird recommendation. All the dietary stuff, drink more water, and see if you can go back to black coffee. It's surprising how many fatty liver patients I see and they don't drink coffee, or they drink coffee and the coffee has been just
It's been
so much cream and sugar,
mutilated.
it's no longer coffee. And so, and those studies do show that if you add a bunch of stuff to it, you probably lose the health benefits, which is not too surprising. But black coffee, my friend, is still key.
So not sugar, 2 pounds of cream, and then a little bit of coffee on it, right? You
Yeah.
actually have to drink coffee. Yeah.
Yeah.
And I was just going to ask briefly, is that antioxidants in the coffee? Is that what
Yeah,
they're
it's probably a
attributing it
mixture of antioxidants within the coffee that does the predominant thing. And then, even the cardiologist, this is how nuanced people have gone, and it is whether it's filtered or not filtered is like a debate right now within coffee. That's just because we've done too many studies on coffee. We're getting that nuanced about it.
That's right.
There's some things in the coffee that the filter takes out. It's probably better for the heart and maybe not as good for the liver and things like that.
Yeah, very good. And we are not saying everybody should take 5 cups of coffee, but there may be some health benefits there for your liver if you do enjoy coffee, and you may get some secondary benefits there. So good stuff.
Interestingly, they didn't see it with tea, which is funny because we think of green tea being a really healthy thing, and it still is. But in terms of the liver health, you didn't see that same effect.
Yeah. This is not in a textbook, so you guys don't quote me. I also suspect you move your bowels better with coffee. And I don't know if that's a tertiary effect, something else that they're not looking at that may have some gut positive things as well. You know what I'm trying to say?
I think just in general, good bowel transit's always important. I don't know if that adds to the liver effect because I think you're absorbing all those nutrients and antioxidants early on. But that is the most common thing that I see in clinic is people just don't move their bowels enough. But if they drank more water, ate more vegetables, I probably would have less patients.
Very good. Dr. Fitch, we really appreciate your time. We'll definitely have you back on the show. If you got one thing from this episode, it's diversify your diet. Everybody, let's look to try new foods. maybe try some of this fermented food that Dr. Fitch has recommended. If you enjoyed this episode, please like, subscribe, share it with somebody that you love. Thank you for tuning into the Doctor Next Door. Take care of yourself. Take care of your people.